You expected to feel joy. You were told you would feel joy. And maybe you do have moments of it, but mostly what you feel is something else entirely. Exhausted, disconnected, not bonding with your baby, even though you love her so deeply, and terrified that means something is wrong with you. Maybe you feel irritable at everyone around you for reasons you can't really explain, or anxious in a way that doesn't match the situation. Or you just feel flat, kind of empty, going through the motions. You wonder if this is what everyone meant when they said that the newborn phase is hard, or if something is actually wrong. You wonder whether feeling this way makes you a bad mother. You haven't said any of this out loud because how do you even say it? So here's what I want you to know before we go any further. This is not who you are. This is what perinatal mood disorders can do. And you are not alone in experiencing this, not even close. Today, I'm going to walk you through the difference between baby blues and postpartum depression, what perinatal anxiety looks like, who is most at risk, and what treatment actually looks like, including the really important question about medication while breastfeeding. So let's start with the baby blues because this is something the vast majority of women experience. Baby blues affect 80 to 90% of women in the first 1 to 2 weeks after delivery. Tearfulness that comes out of nowhere, mood swings, a little irritability, feeling overwhelmed or emotionally raw, a hypersensitivity to everything. And the reason this happens is really hormonal and it is pretty immediate. In the days following delivery, estrogen and progesterone don't just decline gradually, they drop sharply and rapidly. And this is one of the most significant hormonal shifts the human body ever undergoes. Your brain, which has spent 9 months adapting to elevated levels of both hormones, estrogen and progesterone, is now recalibrating. The emotional volatility of the baby blues is a direct reflection of that neurochemical adjustment. Baby blues typically begin within the first few days after delivery and resolve on their own within 2 weeks. They don't require treatment beyond rest, support, and time. They are not a sign that something is wrong with you. They are a sign that your body went through something enormous. The baby blues are not a disorder. They are a normal hormonal response to delivery, but they're also temporary. And if they're not temporary, that matters. The key word in all of this is temporary. If you are more than 2 weeks postpartum and the tearfulness and emotional overwhelm have not lifted, if they have gotten worse or new symptoms have appeared, that's a sign to pay closer attention. So here's an important distinction. Postpartum depression is not just baby blues that didn't go away. It is a distinct clinical condition and it often looks different from what most people expect. Most people picture postpartum depression as crying all the time or being unable to get out of bed, and that is one possible presentation, but here's what it can also look like and what frequently goes unrecognized. Symptoms can include irritability and rage that feel out of proportion. Maybe you're snapping at your partner or feeling this surge of anger you can't explain, and that often frightens you. Or maybe you have just some emotional numbness or flatness, not really crying, but not really feeling much of anything either, kind of just going through the motions without feeling present. Difficulty bonding with your baby can be a feature, feeling disconnected or detached, which is really terrifying when you love your child so deeply. And intrusive thoughts, which are unwanted, disturbing mental images that you would never act on, but that won't stop coming. I talked a lot about intrusive thoughts in last week's video on perinatal OCD, but intrusive thoughts can be a feature of postpartum depression or anxiety too. If you want to learn more about that, you can watch last week's video. Another symptom can be not being able to sleep even when the baby is sleeping, or having a sense of deep inadequacy, a persistent feeling that you're failing, that you weren't cut out for this, or that your baby would be better off without you. Maybe you have loss of interest in things that used to matter to you, your relationships, your body, yourself, your hobbies. And in really severe cases, you might feel hopeless or like your baby would be better off without you, or you might even think about taking your own life. This is, of course, an emergency, and if you're feeling this way, tell someone immediately, call 988, or go to the nearest emergency room. Postpartum depression affects up to 20% of women, making it the single most complication of pregnancy in the United States. It's not a rare complication, it's the most common one. Perinatal mood and anxiety disorders are more common than other conditions that we hear more about, like gestational diabetes or preeclampsia. And tragically, suicide is one of the leading causes of maternal death in the first year postpartum in the United States. And yet, the silence around it remains striking because there is still so much shame attached to struggling after having a baby in a culture that tells women they should feel grateful and joyful at every moment and naturally capable of this. Postpartum depression can begin any time in the first year after delivery, not just in the early weeks. And it can also begin during pregnancy, which is why we use the term perinatal rather than postpartum most of the time. And it doesn't only affect birthing mothers, fathers, and non-birthing partners can also develop postpartum depression, although it is less common and caused by a different mechanism. One more piece of the picture that is important to name: perinatal mood and anxiety disorders are an umbrella term that we often use, and anxiety is often a dominant symptom rather than depression. We don't have as much research on perinatal anxiety alone as we do on depression, but they often go hand in hand and the symptoms overlap. Postpartum anxiety can certainly exist without depression and can look like relentless worry that won't quiet down. Usually it's about the baby's safety or about your ability to cope or about everything that could go wrong. It can look like difficulty sleeping even when you're exhausted because your mind won't turn off, or you have a low level, constant dread that something terrible is about to happen, even though logically you know it probably isn't. Intrusive thoughts, again, usually of unwanted harm coming to the baby, can also be a feature. Again, if you want to learn more about intrusive thoughts, check out the video I did last week on perinatal OCD. But intrusive thoughts can occur in postpartum anxiety without having OCD. The distinction can be nuanced, and the diagnosis requires a careful evaluation by an experienced reproductive psychiatrist. Here's an important point. Many women with perinatal mood disorders have both anxiety and depression simultaneously. And many women whose primary symptom is anxiety get missed entirely because doctors and nurses or other clinicians are screening for depression and not looking closely enough at the anxiety presentation. I'm going to go much deeper into anxiety and panic during next week's video on anxiety and panic during pregnancy, so follow me for more. So now let's talk about who is most at risk for developing these conditions. While any woman can develop a perinatal mood or anxiety disorder, certain factors increase the likelihood, and knowing them can support earlier identification and more proactive care, and sometimes even prevention. So what are the risk factors? A personal or family history of depression, anxiety, or any psychiatric illness, a prior history of postpartum depression. Each subsequent pregnancy carries an increased risk. A history of premenstrual dysphoric disorder, or PMDD. That same hormonal sensitivity that drives PMDD also raises your perinatal risk. Poor or limited social support, multiple gestation pregnancies like twins or triplets, having a baby in the NICU, being part of a military family, significant life stressors, financial strain, or relationship instability. This list isn't exhaustive, and if several of these apply to you, that is not a reason to feel anxious about what will happen. It's a reason to have a conversation with your doctor early, ideally before or during your pregnancy, so that the support you need is already in place and you can be as well prepared as possible. So now let's talk about treatment and what actually works. The most important thing I want you to hear is this: perinatal depression and anxiety are highly treatable. This is not a condition you have to push through alone or just endure. First, let's talk about psychotherapy. So there are two forms of therapy that have the strongest evidence base for perinatal mood disorders: cognitive behavioral therapy and interpersonal psychotherapy. CBT works by identifying and shifting the thought patterns and behaviors that sustain depression and anxiety. Interpersonal therapy focuses specifically on relationships and role transitions, and the transition to motherhood, which is often referred to as matrescence, is one of the most significant role transitions a person can experience. Therapy alone, along with other supports, can often be very effective on its own. For moderate to severe postpartum depression and anxiety, though, a combination of therapy and medication has been shown to be the most effective approach. First line medications are typically the SSRIs or SNRIs, things like sertraline, escitalopram, fluoxetine, venlafaxine, for example. The right choice depends on your personal history, your prior medication experience, your symptom profile, your medical history, and your preferences. So now I want to address the question that almost everyone has. Is it safe to take medication while breastfeeding? The short answer is that in the vast majority of cases, taking an antidepressant is not a reason to stop breastfeeding if breastfeeding is desired. We have strong and numerous safety data on the most commonly used antidepressants during breastfeeding. Only minimal amounts of most medications pass into breast milk, and the risk to the nursing infant is considered very, very low. Again, for most women, taking an antidepressant is not a reason to stop breastfeeding if that is something you want to continue. And here's the reframe that I think matters most. Untreated illness is also an exposure. A mother who is deeply depressed or severely anxious, who can't sleep or connect with her baby or care for herself adequately, that also affects the baby. Untreated perinatal depression has been shown to affect mother-infant bonding, infant neurodevelopment, and the child's long-term outcomes. The goal of treatment is not to avoid medication at all costs. The goal is to minimize harmful exposures overall, and often the risks of untreated illness are greater than the risks of treatment. Of course, every decision about medication should be made collaboratively and individually with a full conversation about the risks and benefits of both treating and not treating. And finally, let's talk about support and lifestyle. Building a stronger support network, improving nutrition, incorporating gentle daily movement, and protecting sleep wherever possible are all part of the picture. They're not substitutes for clinical treatment when it is needed, but they are real contributors to recovery and they matter. It really does take a village. If anything in this video resonated with you, if you recognize yourself in any of it, please know that what you are experiencing has a name, it's not your fault, and it is treatable. You don't have to keep pushing through this alone. In upcoming videos, we're going deeper on anxiety and panic, specifically during pregnancy, what it looks like, why it happens, and what helps. Subscribe so you don't miss it. And if you're in New Jersey, Florida, or Texas, my practice information is in the description. I would be honored to be a part of your care. And again, if you are having thoughts of harming yourself or your baby or thoughts of suicide, please call or text 988, the Suicide and Crisis Lifeline, or go to your nearest emergency room. You don't have to manage this alone, and help is available.